everyone, and welcome to Frontline Perspectives on BabyChecker, Field Experience and Insights. I'm Katyayani, and I'll be your moderator today. It's great to see so many participants joining from across the globe, and thank you so much for being here. Next slide, please. Yeah. According to the World Health Organization, over 700 women die every day from preventable causes related to pregnancy and childbirth globally. These deaths, along with severe maternal morbidity, disproportionately affect women in low-resource settings. Today, we'll hear from partners and clinicians around the world who are using BabyChecker in their own regions, from Ethiopia and Sierra Leone to Guatemala and Honduras. They are all working to improve maternal health care in real and measurable ways in their countries. Next slide, please. So before we get started, just some quick notes. This session includes simultaneous translation and interpretation in French and Spanish. You can select your language by clicking the interpretation icon at the bottom of your Zoom screen. Similarly, we also have a Q&A chat box. If you have any questions for any of our speakers or us, please post it in the Q&A panel. Our team will monitor it and direct questions to the right person. Also note, we have a Q&A session right at the end of the webinar. So please stay tuned till the end if you want answers to your questions. Next slide, please. Yeah. Without further ado, let's begin with a word of welcome from Akshay Rajagopal, my colleague and a project manager at BabyChecker from Delft. Akshay, the floor is yours.
Thank you, Katya. Next slide, please. Next slide. So welcome everyone to the annual webinar of BabyChecker. Good morning, good afternoon, good evening from all our partners and clients who have joined from different parts of the world. Today, I'll give a brief introduction to Delft Imaging and a brief overview of BabyChecker. So Delft Imaging, it's a social enterprise which is based in Netherlands. We are pioneers in developing screening solutions, mainly for tuberculosis and maternal health, as in pregnancies. We have our regional offices based in Ghana, Nigeria, and Indonesia. We have projects in more than 85 countries with our solutions for tuberculosis, and have screened more than 32 million people with our solutions of tuberculosis. Next slide, please. Yeah, a bit of history of where we come from. So our roots go back to early 20th century, where we used analog X-rays and mobile clinics to screen tuberculosis in Netherlands and also in Europe. And with the advancement of technology, digital X-rays and integration of AI solutions, currently we have developed screening solutions which is integrated with artificial intelligence, which is popularly known as CAT4TB, computer-aided detection for tuberculosis, and have implemented in more than 85 countries. So we work with technical agencies, funders, and implementation partners in the ground to implement the solutions. We also have local partners in the countries we operate, which give us a strong support system in all the countries like Sub-Saharan Africa, Latin America, and Asian countries. We are also the inventors of backpack X-rays, as you can see in the image, Delft Light backpack X-rays, which is portable and can be taken to the hardest reached places in the world. With the implementation of artificial intelligence coupled with this detailed X-rays, we are also removing the need of human interpreters, where AI does the job of interpretation, giving risk assessment to different like health abnormalities. Next slide, please. So with this expertise of decades of working in different countries, low middle income countries, working with partners and different implementing organizations, we developed BabyChecker, which is basically the screening solutions for pregnancies. Next slide, please. Yeah, so as Katya introduced briefly, the situation of maternal health globally has a very big disparity. That is, every 2 minutes, a woman dies due to pregnancy or childbirth, and that sums to around 700 women dying from pregnancy or childbirth every day. And the fact that more than 90% of this maternal death happens in low resource setting is very harsh. This itself shows a huge disparity in health access, health equity of those things, which can be matched or met. The gap can be filled by digital solutions and recently with the integration of AI solutions. Next slide, please. Yeah, here you can see some of the stats on maternal mortality ratios in few countries. And while the SDG target for maternal mortality ratio is less than 70 death per 100,000 live birth by 2030, most of this low income countries, low middle income countries, and especially in sub-Saharan African countries, they are very high, and that gap is very difficult to fill. And over the past couple of years, Delft Imaging with BabyChecker has worked with a lot of implementing partners in these countries to ensure that pregnant woman receives proper care, proper ultrasound or timely ultrasound screening, and to reduce this maternal mortality gap or ratios. Next slide, please. Yeah, some of the reasons of this high maternal mortality ratio in these countries is due to lack of accessibility of ultrasound, or even if there are ultrasound available in these countries, there are lack of trained sonographers who could undertake an ultrasound device. And so the idea of BabyChecker is to minimize this gap of accessibility and availability of ultrasound, making it portable and bringing to the point of care where community healthcare workers can use this device and provide a timely screening for the pregnant woman. Next slide. Yes. So as I said, we have designed BabyChecker, which is very portable, that can be carried in a like a small pouch. And we have designed this for community health providers, frontline healthcare workers, to use this at antenatal care services, door-to-door services, where they can screen pregnant women very early upon their pregnancies and can provide indication on their risk conditions, and like in a timely manner, so they can get the proper care what is needed in a pregnancy journey. Next slide. Yeah. So what is BabyChecker and how does this function? So BabyChecker is basically the AI, the artificial intelligence that identifies risk in ultrasound scan. So as you can see in the image, it comes in a very portable backpack, a portable case with an ultrasound probe and a mobile phone. Next slide. Yeah, how does it work? So we have designed BabyChecker in a very simplified manner that it functions using an obstetrics 6-sweep protocol. So usually this 6-sweep protocol is designed for settings where there is lack of trained sonographers who can do a proper ultrasound scan with all those expertise which is required. But with the 6-sweep, it is basically 3 vertical sweeps and 3 horizontal sweep across the abdomen, and this can be captured in less than 2 minutes. And in each sweeps, the ultrasound probe captures the image, and the AI does the interpretation in the background. And once the sweeps are complete, the AI gives an indication on the risk parameters, which as of now, BabyChecker gives indication on gestational age, fetal presentation, multiple pregnancies, and placenta localization. So this information is given in less than like 5 seconds, and it gives the risk parameters are given in color code, so traffic light systems, which basically is red, green, and yellow. And based on that indication, the health provider can advise the pregnant woman for a higher consultation or not. Next slide. We have created BabyChecker for resource efficiency. So with our expertise working in like many low-income countries, we know what the contextual conditions are, what are the limitations, infrastructure limitations. So we have developed BabyChecker like so. So fit that it can be functioned effectively in the settings where we want it to gain maximum value. So there is no additional training required for use of BabyChecker. Usually with such kind of interventions, detailed solutions, there are bundle of modules or weeks of training that comes along with such interventions. But with BabyChecker, we have designed a 3-minute training video which is built in the app, in the application, and the health workers can watch that videos multiple times, if they have doubt and can do a good quality scan based on that. We also have results from the ground which verifies the usability of this training video. It functions completely offline, so there is no requirement of internet to use BabyChecker. There is no prior experience required to use this device. So BabyChecker, as I said, is designed for frontline healthcare workers who has no uh, background knowledge or previous knowledge on how to use an ultrasound, or perhaps they barely have some information on how, or knowledge on how to use a smartphone. So with that, we have designed, keeping in mind these are our target audience and they should be able to effectively use this device. There is no constant power required to use BabyChecker. So once you charge the mobile phone, the probe is connected to mobile phone, and that is sufficient for using the device. Next slide, please. A bit on the hardware side of the BabyChecker. So as you can see that it's only an ultrasound probe and a mobile phone, and it is designed for it's a very robust hardware designed for tough conditions, and we have very minimal maintenance issues in the past. So it is really designed for operating in high temperature and in a very conditions which you can imagine in low resource settings. And it is built for Android and not for iOS. Also, the battery capacity of the phone is 5 to 6 hours. So from our experience, if with a fully charged mobile phone, it is usually sufficient for an NC session, like 30-50 scans per day. Next slide, please. Yeah, this shows a pictorial representation of a journey of a pregnant woman with BabyChecker. So basically, BabyChecker is deployed at an antenatal care facility. It can be a primary healthcare center or community health center or an outreach program or mobile clinic, where the pregnant woman receives an BabyChecker scan, and within fraction of seconds or few minutes, if you consider the whole entry point, it gives an indication on the risk condition. And if it's a high risk condition, the client is directed to refer to a higher hospital for better consultation and detailed result. If it's a low risk, then they can schedule the next visit. So this is how the journey of pregnant woman happens along with the BabyChecker. They are also enrolled in the health systems of the, like, at the communities, and also can take other services which are provided during the pregnancies. Next slide, please. Yes. Before I give my floor to give the floor to Julio, I would thank our research collaborators and clients who have been part of the journey of BabyChecker for the past years. And so far, we have BabyChecker have projects or have projects, research projects, and commercial projects in more than 13 countries, Latin America, Africa, and Asia, and have screened more than 9,000. Have completed more than 9,000 scans, and more than 200 frontline healthcare workers are using BabyChecker. to effectively screen pregnant women at their communities. Thank you.
Thank you, Akshay, for the warm welcome and introduction to Delft Imaging, as well as the work done with BabyChecker. Next slide, please. Yeah. Now, to give us a look at the latest development from the research and technology side, I'd like to invite my colleague, Julio Lopez, the head of R&D for ultrasound at Delft Imaging. Julio, the floor is yours.
Thank you very much, Katia. Well, first of all, I want to thank everyone for attending this webinar. It is really nice to see the number of
Julio, you're on mute. We cannot hear you.
Can you hear me now?
Yes, thank you so much.
Okay. So as I was saying, it's a pleasure to be here, and it's also thank you. I want to thank everyone for attending the webinar. I am very excited to see the number of people that is here and to recognize several names in the attendee list. My role in this webinar is a little bit to draw the picture of what we have done so far in the last few years related to research and towards the ethos of Delft Imaging, that is developing high-tech solutions for the lowest settings and make sure they are scalable and with our local partners. So if we go to the next slide, 2 slides actually. Our journey started BabyChecker about 6 years ago, back in 2017, and it was really a clear opportunity for us to work as a social enterprise to dive into something like, in this case, it was antenatal care. We already, like Akshay explained before, like we already had experience with computer-aided detection and with medical imaging in the tuberculosis area, and we thought like it was a topic that it was very much not seen and that it made a lot of sense to actually jump into it, and we as a company want to build solutions that are scalable medical technology to reach the hardest and more complicated communities. So then in 2017, it's where the research and development started, where we partnered with Radboud University in a PhD thesis that leads to the development of the BabyChecker concept. Like later on in 2019, we had the proof of concept where we tested the prototype in Ethiopia. We confirmed the ease of use among the midwives with a 2-hour training. That was already a long time ago. Now we have the BabyChecker video tutorial, for example, which we have seen that it can actually show a midwife how to use BabyChecker within 3 minutes, for example. Then in 2020 to 2023, we were developing the MVP, the minimum viable product, which was pilot in Sierra Leone, Ghana, and Tanzania. And this was to optimize the product to be launched and to actually like start really being used and acquire and see how it can actually be used in a real setting. And it was in 2023 when we have the go to market where it's become a product that it's implemented in several sites, starting with the early adopters in Africa and Latin America. So for us, BabyChecker was built on top of a point of knowledge that it's already mentioned, that a woman dies every 2 minutes due to childbirth, and that 95% of those deaths are actually preventable. So there is a reason why the WHO recommends ultrasound, and why in many developed countries, like women actually undergo ultrasound. So for us, or for Delft Imaging, it is important to invest in low and middle income countries to try to increase the early detection, the timely referrals, and to reduce the inequities on healthcare that is happening because of the lack of trained sonographers, for example, or the lack of knowledge. Like it's in these rural communities where it's harder to reach and to train women into actually using BabyChecker. So then back to the technology and the things that we are doing. If we go to the next slide. How does it work? So BabyChecker is basically a six sweep protocol. It has 3 longitudinal sweeps, 3 transversal sweeps. So within every sweep, it's around 7 seconds. So within each sweep, we collect, or the user that is actually using BabyChecker collects the information that then can be used by artificial intelligence to identify risk factors. Like in this case, we use the gestational age, or we identify the gestational age, we identify the estimated fetal weight, that this is a new feature that we have been working, and it will be present in BabyChecker in the Q1 for next year, for example, the fetal presentation, the placenta localization, and the multiple pregnancies. We are also actively working on other features that we know they are important, like the amniotic fluid volume, the heart rate detection, or others to come. So it's a whole process of actually performing, like, as probably a lot of you understand, like artificial intelligence requires data to actually work. So we are setting up protocols and validation protocols and projects where we can actually collect data and test the BabyChecker artificial intelligence. So we can also make sure that the artificial intelligence work as we expect it to work. Therefore, in order to develop new features and continue improving the features that we have, we are setting up these projects that are that allow us to keep researching and bringing this technology that we think it is really impactful and can really change and democratize the way that that women have access to antenatal care, especially in these areas and these really hard to reach communities where we are. So if we go to the next slide. Like we have been working, like for example, like in collaboration with the Key ID, with the Royal Tropical Institute, like we have available in preprint the evaluation of the usability and practicality of artificial intelligence-enabled smartphone-based obstetric ultrasound in Sierra Leone. We are also working on other aspects, for example, the regulatory aspect. We are actively pursuing for going for CE and FDA, and we are also expecting to have them for the next year. And we are preparing, as I was mentioning as well, new studies, like one that we are almost ready to be shipped in this case is the point of care ultrasound validation, collaboration with the Gates Foundation and the Fetal Medicine Foundation. And a part of that, we are performing research both Southeast Asia, South America and Central America, and also in South and Sub-Saharan Africa. So we keep collecting data from a broad population, so we can also make sure that our artificial intelligence works in all these different settings. Also, we are actively collaborating in Europe as well, with, for example, the Radboud University, where we keep working together and try to bring also new research and that can actually be hopefully integrated and can be used in the community, in the science community, towards improving and seeing how we can also collaborate together. Because in the end, it's also very important, like this technology is here to democratize, and we really want to make something that can be used, but like the research is there and that can also openly be used in a way to really improve and makes a difference. That it's what we want to achieve in the end. We go to the next slide. So we have also, for example, I work on improving the training video. This training video was something that we have. The old training video, it's a video that we are really proud and it's really nice from us. It's a video that was recorded in Sierra Leone and it's a beautiful video that we still keep and we are still using in some places. But we also have a new training video that we have done in collaboration also with the users of BabyChecker, which are a very important part of our product. Like we really try to include them in most of the aspects or in all the aspects, so we can make sure that BabyChecker can actually help them in the way that they are. We don't want to change the way that they work. We want to make sure that they can actually integrate within their day-to-day routines. So in this case, this video, it's done in order to help them be able to use BabyChecker more effectively from the moment that they open the BabyChecker package, which is over there, and Akshay already mentioned that. We'll go to the next slide as well. Other things that we are also actively working with BabyChecker is a whole complete solution. So it's not only for the users, which is a very important part of it, or not only for the ground users, the midwives that are actually using the BabyChecker in the field, but also for the organizations or for the governments that are actually also following how BabyChecker is being used, understand, and they want to understand, like, okay, how such device is actually affecting, and it's creating an evidence that antenatal care mortality can be reduced in a way, or how can you track actually the risk that are happening within the pregnancies in specific areas. So in this case, for example, like the BabyChecker dashboard, which is also gonna be ready before the end of the year, will be, and for the early adopters, which I think it will be ready at the end of this month, we will have the dashboard, which is a platform where an organization that it's actually using the BabyCheckers will be able to enter, will be able to see how is the actual BabyChecker being used, which risks are detected, like the amount of multiple pregnancies, the amount of placenta, of low placentas or non-cephalic presentations there are. Also, they will be able to understand how the users in the ground, the midwives, are actually using the device, to also see, like, for example, if someone needs to watch the video tutorial again, so we can track these kind of circumstances, so then we can make sure that the technology is being used to the best of to the best that it can be, and it can also help digitalizing the infrastructure or the areas where there is not a lot of digital. We know, or I've been in many places, especially in sub-Saharan Africa, where the healthcare still uses paper and pen and very big books, where they have to then bring them to the district health area, where then they are digitalized in the best of the cases. Like, this still happens. So with BabyChecker, what we also, with the dashboard in this case, what we want to do is to also facilitate this. Like, every scan that can be done with BabyChecker could be, of course, fully anonymous. Like, there is no name of clients or anything. It's fully anonymized. With it can be shared, and it can be taken the overall statistics, let's say like that, on how the distribution over trimesters, for example, the distribution over risk, and this can also be integrated with other platforms, like, for example, the EHAS2. Like, it's something that we are actively working because we think it's important. And then with this short presentation, just guiding and presenting the ideas of what we have been working so far, and a little bit the goals that we will want to also have for the next year, that it's really obtain the regularization and CE and FDA, and going forward, increasing the amount of features that are actually detected by BabyChecker. I'm gonna leave the floor to the actual protagonist of today, which are the people that are gonna tell us their experience and how they have been using BabyChecker. So thank you very much again for being here. And yeah, I hope you enjoy our participants. Yeah, our protagonist of today.
Thank you, Julio. Next slide, please. Yeah, next slide, please. Yeah, thanks, Julio. It's really exciting to see how BabyChecker continues to evolve, and how innovation based on ground reality and field feedback can actually make practical difference around the world. Now that we have heard about the innovation behind BabyChecker, let's move into how it's being used on the ground by our partners in the field. So before we introduce our next speaker, I want to quickly remind you again that this session includes simultaneous translations in French and Spanish. You can select your language by clicking the interpretation icon at the bottom of your Zoom screen. Also, if you have any questions for any of our speakers, please post it in the Q&A panel. Our team will monitor it and direct questions to the right person in the end of the Q&A session, right? The general chat box is only open for general comments and greetings. So without further ado, let me introduce our first speaker, Riccardo Lazzaro. Mr. Lazzaro is a health coordinator at Doctors with Africa CUAMM in Ethiopia. He is going to be presenting on the preliminary results of BabyChecker use, an AI that analyzes ultrasound scans in the Somali region of Ethiopia. Riccardo, the floor is yours.
Thank you very much. Nice to meet you, everybody. As was introduced, I'm Riccardo Lazzaro, Health Coordinator for CUAMM Ethiopia, Doctors with Africa CUAMM. Next slide, please. Okay, here is the preliminary results of a BabyChecker use, AI that analyzes ultrasound scans in Somali region, Ethiopia. This is the group of people that collaborated with this research. Most of us, we are from Doctors with Africa CUAMM, plus some people from Delft Imaging and the Somali Region Health Bureau. Next slide, please. Okay, a small introduction about Doctors with Africa CUAMM. We are an NGO, the first Italian international health organization established in 1950. It's active even in Ethiopia since 1980, aiming to strengthen health system and improve sexual, reproductive, maternal, neonatal, child, and neonatal and nutrition services. CUAMM began operations in Somali region in 2020. In October 2024, as part of one of its projects funded by Fondazione Elena, CUAMM piloted the use of BabyChecker at the Dawanaji Health Center in Fanfan Zone, Somali region. Next slide, please. Okay, about the background, in Ethiopia, we have high maternal and neonatal mortality. Most of deaths are preventable with timely risk detection and skilled care. In Ethiopia, limited ultrasound access in rural area hampers early detection of pregnancy risk, such as malnutrition, malpresentation, placenta previa, and multiple gestation. WHO recommend early obstetric ultrasound as a core component of routine antenatal care, but is not widely available outside urban centers and area. Innovative tools such as BabyChecker may empower frontline health workers to detect pregnancy risk early and improve antenatal care uptake. Next slide. Briefly about BabyChecker, I think there were quite a competent and big introduction about it. BabyChecker is an artificial intelligence device that analyzes obstetric ultrasound scans to identify potential risk factors in pregnancy. Scan can be easily acquired with a point-of-care ultrasound and by a frontline healthcare worker within 2 minutes. A frontline healthcare worker can be easily use the ultrasound without prior experience. BabyChecker was developed by Delft Imaging with the collaboration of various partners, and the first version was launched in 2023. Next slide, please. Okay, let's go to the preliminary study result. The primary objective of the study was to assess the BabyChecker usability, comparability, and adoptability for the practical use in the clinical setting and strengthening the antepartum care in the rural setting in Ethiopia. The secondary objective of the study was to ensure that BabyChecker use is helping to achieve the following key outcomes: increase the identification of pregnancy-related risks, such as risky placenta localization, fetal malpresentation, multiple pregnancies, and other risks detected outside the typical antenatal care indications. Additionally, increased number of antenatal care attendance and frequency of visit, including earlier attendance. Next slide. So the study setting, as we say, Darwanaji Health Center in Somali region, Ethiopia. The time frame of the study was October 24, June 25, for a total of 9 months. The context was a rural primary healthcare facility providing antenatal care and skilled attendance with a delivery room. The support of the study mainly was... can you still hear me?
Yes.
Yeah. Okay. Okay. Sorry, the connection is not stable today. I was saying the support, the implementation was done by Doctors with Africa CUAMM in collaboration with the Somali Regional Health Bureau. Midwives were trained and supervised on BabyChecker use, and midwives were the one of the health center. Next slide. Study design. The study was a facility-based prospective pilot intervention design study using a pre and post comparison design. Study participants and sampling, inclusion criteria, pregnant women visiting for antenatal care or stillbirth attendance at the Darwanaji Health Center during the study period. The follow-up was with women with identified risk that were rescan and refer as needed. Next slide. Data collection and method. The tools we used were basically the antenatal care facility registry and the daily registration book for data recording of the BabyChecker. Concerning the monitoring, in October 24, all midwives were trained using the tutorial video that was shown before this presentation and started the on-job training. In January 25, an expert obstetrician gyne gave a technical support to the midwife on the ground. And between October 24 and June 25, the monthly supervision and mentoring by a trained health officer was done, and data collected were collected monthly on a dedicated record. Concerning the data quality, the performance were automatically transmitted to Delft imaging for cross-checking and a third-party verification of dedicated records with Excel MS database was done, particularly by our regional head of program. Next slide, please. Concerning the data utilization and data analysis, we made for this initial part, we did the descriptive statistic, so frequency, percentages, means, and ranges to summarize participants' characteristics, scan quality, and antenatal care attendance. We are planning to have a pre and post 1 year intervention, monthly antenatal care visit, first trimester contact, and follow-up visit compared. The tool was Excel MS, and the association is in plan to have exploratory analysis to examine the relationship between scan findings using Stata 18. Next slide. Ethical approval was obtained by the Somali Regional Health Bureau in October 24, and the verbal consent were also asked to all participants. Next slide. Here we are with the key result of the preliminary finding. A total of 2,830 visits were done during the 9 months data collected. The total scanned women were 138 women. regarding the risk detection by the BabyChecker system, 21%, meaning 29 fetal malpresentation, and 25 low-laying placenta cases were identified. Referrals, 5 women were referred to a higher level of care versus 20 patients that had to be referred by the system. 120 were the women that receive a follow-up at the Darwanaji Health Center. On the right hand, you can see that initially we had a kind of standard antenatal visit with a midwife. Here there is a mistake. General practitioner is not present in the health center. Suspected obstetric complication were sent for the BabyChecker visit. And then those who where the complication were confirmed, when the complication were confirmed, were referred, were suggested to be referred to a higher level of care. Next slide. Concerning the scan quality. Sorry, concerning the scan quality. Can you go, sorry, previously? To the previous slide? Yeah, thank you. Scan quality, we have 65% scan sufficient quality. Usability, 11 patients out of 138 were rescanned. We found that while midwives found BabyChecker user-friendly and reliable, the performance seems to change from person to person. We can see from the table below the use.
Unfortunately, we can't
Can you
hear
hear
you,
me?
Riccardo. Yeah, now we can hear you.
Yeah, you can still hear me. Okay.
Perfect.
So I was saying user B got 100% percentage sufficient scans, while user E had only 20% sufficient scans. Next slide, please. Okay, concerning the comparison, 6 months comparison, January-June 24, January-June 25, we realized there were quite a big increasement. We can find in the second column the first period, and in the third column the second period. So antenatal contacts were averagely 280 in the first period, 330 averagely per month, 338 in the second period, with a plus 20% difference. Total first antenatal contact were 52 in the first period, 55 in the second period as monthly average, with almost 6% plus difference. Total first antenatal care contact in the first trimester were 24 in the first period and 26 in the second period as monthly average, with a plus 8% difference. And surprisingly, the visit, antenatal care visit 7 and 8 were 0 in the first period and around 67 in the second period as monthly average. I have to say here, this attracted quite a lot our attention, so we are going back to the records to understand, and it seems that it was a problem, not a quantitative problem, but more a qualitative problem of data that were not collected properly and were kind of informal visits that were done, so were not recorded, and that's why we have a 0 in the first period. But as I say, these are preliminary findings, so things might be different, slightly different from these findings. Next slide, please. So limitation of this study, preliminary results are limited by a sample size and short follow-up and require confirmation in large-scale studies. The technologies
potential to facilitate early complication detection may be undermined by cultural barriers, patient economic challenges, and health center logistic issues, collectively impeding a timely referral to hospital care. Consistent training and supervision will be key to sustaining high standards of use and maintain appropriate records. Next slide, please. Discussion support WHO, the study support WHO recommendation for early obstetric ultrasound and align with studies showing AI-assisted tools can improve risk detection in low resource settings. BabyChecker seems to be a feasible, user-friendly, and effective for detecting pregnancy risk in rural antenatal care setting, where a source of electricity is available. I've heard in the previous presentation that the level of battery and the presence of electricity is quite the key, and we found that is also important because the battery can finish soon. Additionally, antenatal care reattendance increased more than anticipated. Scan quality was high despite minimal training, indicating rapid adoption and acceptability among midwives. However, more comprehensive training may be required for center members of the team. Next slide. In conclusion, preliminary findings show that BabyChecker initiative demonstrated a high practical, user-friendly, and adoptable solution for improving ultrasound screening in rural areas. The implementation also showed that BabyChecker can play a vital role in early identification of pregnancy-related risks, facilitating prompt referrals and timely intervention, and maybe contribute to improve antenatal compliance. Cultural and logistic challenges should be addressed before starting the implementation. Moving forward, expanding the use of similar technologies to additional rural health centers is critical to achieving wider and higher impact. Next slide. Here we have some pictures of the implementation. In the center up, you can see how in these health centers, but is quite common in the area. They are having banners all over the health centers to show the performance, the monthly performance and the yearly performance of the antenatal care. In the center low, you can see the ambulance that was used by the project and by the health centers for referral. On the right-hand side, you can see a healthcare worker that is working and using the BabyChecker on a woman. On the left, finally, you can see the BabyChecker use. Here I found it interesting to highlight that there are scars on the belly of the patient, of the woman. This is quite typical in the Somali culture. Whenever a lady has some problem and some issue related to the pregnancy, they make scars to bring better to bring good luck. Next slide, please. Thank you very much. In Amharic is Amasagenal.
Thank you, Riccardo, for those valuable insights and for showing how you, with BabyChecker, are supporting healthcare workers and improving maternal health outcomes in Ethiopia. I see a lot of questions at the general chat box. So before I introduce our next speaker, I want to very quickly remind everyone that this session includes simultaneous interpretation in French and Spanish. So you can select your language by clicking the interpretation icon at the bottom of your Zoom screen. If you have any questions for any of our speakers, please post it at the Q&A panel. First, make sure that your questions are read and that we can pick it up during the Q&A sessions that's right in the end of this webinar. Next slide, please. Our next speaker is Dr. Charles Elijah. He's the medical superintendent at the Lionheart Medical Center in Sierra Leone. He'll be sharing his experience on the use of BabyChecker in resource-limited settings and how the solution is being integrated into local health systems to reach more expectant mothers. Welcome, Dr. Elijah.
Good afternoon, all. So you may hear some background noise because I am in the hospital. I'll be taking you through the uses of BabyChecker in Sierra Leone, especially in rural settings of Sierra Leone. Of course, in Sierra Leone, it was introduced in the rural setting, and the use of it is for now a lot more common in rural settings than it is in other parts of the country. So I'll be taking you through the advantages that we have noticed with the use of BabyChecker in the rural settings of Sierra Leone. Because Lionheart, where I work, is in the rural setting, the centermost part of Sierra Leone, and extreme rural setting, and the PHUs in our catchment communities lacks a lot of other things that are required for establishment of a standard ultrasound scan. And as a result, we were introduced to BabyChecker a couple of years ago, and we are currently using it in some of our catchment communities. At the facility now, we are even trying to do a validation study to compare the result of the BabyChecker and that of the standard ultrasound scan to see if there are any differences. So far, that one is ongoing, and probably in coming months we will get the result ready. Okay, so I'll be taking you through. Next slide, please. Yes, so next slide. Yeah, so brief table of content. We'll be taking you through the definition, overview of brief overview, and then how the BabyChecker works based on our experience here in Sierra Leone and the advantages that it has over the use of a standard ultrasound scan in the rural settings of Sierra Leone, the limitations and possible recommendations. And then next slide, please. Yeah, so for definition, of course, this has already been defined by Akshay. Of course, it is an artificial intelligence device that is used for ultrasound scan. It consists of the BabyChecker, which is a mobile app itself, and a smartphone with an ultrasound probe that is connected to the smartphone. Next slide. Brief overview. Sierra Leone, a country in West Africa, is one of the countries with the highest maternal mortalities in the world. In 2023, the country's maternal mortality was around 354 deaths per 100,000 live births, according to UNFPA. And of course, a lot has actually happened over the years. It was a lot more worse than what it is now. According to data, about 75%, 74% reduction has been made from 2000 to date. And recent data will actually also reveal, preliminary data already shows that there is a significant reduction compared to this data that was in 2023. And of course, this one has not yet been published. Some progress has been made in this regard, but we are still far from reaching the UN's 2030 Supplementary Development Goals, which says that, or which aims at having a maternal mortality of 70 deaths per 100,000 live births. So though some gains have been made into this, but we are still far from achieving the UN Supplementary Development Goal for 2030. Next slide. Yes, so a country, Sierra Leone is a small country with a population of about 8 million. However, the population is small, but the number of medical staff, especially doctors in the country, is also equally small. We have about 800 medical doctors serving a country's population of about 8 million, which is a significantly small amount. And this is also coupled with inexperience and inavailability of the standard ultrasound scan. Of course, all of these are the challenges that are making it difficult to achieve the UN's 2030 Supplementary Development Goal. Okay, so rural settings in Sierra Leone lack most of the amenities that are in cities, which are required for establishment of the standard ultrasound scan. Among them include the electricity supply. The rural settings in Sierra Leone mostly lack electricity supply, as you may see in one of our catchment communities, Mafe, where BabyChecker is being used. There is no electricity there. And of course, even in Lionheart, which is the town where the hospital is located, there is electricity in, of course, the hospital has 24-hour electricity from the solar energy and the generator, but the township itself does not have electricity. So that is the challenge that can actually affect the establishment of a standard ultrasound scan. One is a limited manpower, small doctor to patient ratio, and then we have a lot of the amenities that are required for establishment of the standard ultrasound scan, coupled with lack of the resources, makes it difficult. And of course, you need the ultrasound scan for reduction of maternal mortality. With the ultrasound scan, you'll be able to identify high-risk pregnancies even before they are term and even before it is time for their deliveries, and then you plan accordingly for them, thereby reducing maternal mortality. But this can be a challenge if you don't have ultrasound scan, which is the case in rural settings of Sierra Leone. Next slide. Yes, so of course has already been explained as to how the use the three longitudinal and 3 transverse sweeps, and then you get the results. Okay, this can be done by practically anyone. You do not have to undergo a specialized professional training for this, as it is required in the standard ultrasound scan. So anyone can be trained to do it. Can be a midwife, maternal and child health aid, MCH aid, any kidder or anyone can be trained to do this one, and it's very simple to use. Okay, so it doesn't require any special technical skills and can be done by practically anyone. Next slide. Next slide. Yes, so this is an image of what I was explaining as to how the 6 sweeps work. 3 transverse sweeps. The first ones are longitudinal, and then the second set of 3 are transverse sweeps. Thereafter, it will give you the results that you results of the gestational age, placenta localization, amniotic fluid, and so on. Next slide. Yes, so this is a picture of one of an MCH aid nurse, a maternal and child health aid nurse, doing a BabyChecker ultrasound scan in one of the catchment communities, which is Mafe village, and a village in an extreme part of Sierra Leone with no electricity. She did not have to do professional training for this. You can actually learn as to how to use it, of course, from the app itself. Okay, and then you can be able to do the ultrasound scan and get the desired result, even without uninterrupted electricity supply. Next slide. Next slide. Yeah, so it has a couple go back to the previous slide. Yes, so it has a couple of advantages. It has a couple of advantages compared to the standard ultrasound scan that we have noticed in our settings. Of course, among the many advantages is that it is very simple to use. You do not have to spend a whole lot of time trying to check for gestational age, trying to check for placenta localization, amniotic fluid, and so on. You can just do the 6 sweeps, and then within seconds you have the results. Okay, so 1, it is very simple. 2, it does not require a high professional skill that is required to do a standard, to establish and do a standard ultrasonography, and then it can be performed by practically anyone, because It does not require a specialized professional skill, a high professional skill. It can be done by practically anyone. Anyone can be trained to do it. It does not also require the availability of uninterrupted electricity supply, which of course you need if you want to be using the standard ultrasound scan, as like the one that we have in our facility at Lionheart. The catchment communities, they do not have the electricity supply, and they also we find it difficult to actually even establish that kind of ultrasound scan, the standard scan at those facilities. Okay, and it does not require it is cost effective relative to standard ultrasound scan, which is a little more expensive, sophisticated and expensive. BabyChecker is cost effective. You only need a smartphone with the app in the phone, and then you get ultrasound probe, you connect it to a smartphone, get the phone charged, and they are set to go. So it is cost effective. Okay, it is portable, can be moved practically from one place to another. Okay, it is not as difficult as it is to carry the standard ultrasound scan. It is very portable. Next slide. Yeah, so in the previous slide were the numerous advantages, there are so many more, but those are the ones that we have been able to realize from the use of BabyChecker ultrasound scan in our catchment communities, in our facility and the catchment community. And then, of course, it has a few limitations because one of the limitations is that for now, it is not available in several parts of Sierra Leone. So that is, of course, for now a limitation. In Tonkolili district, for example, even in our catchment communities, it is not every PHU that is using it, but it is the PHUs that are actually using it are mostly the PHUs where piloting the BabyChecker project in Sierra Leone started and is still ongoing. And then at the facility now, we are trying to do the validation study. So we still have a lot of other communities that actually need portable, very effective and less cost effective, and very cost effective rather, ultrasonography to be done to help prevent maternal mortalities. But of course, the device is still being developed, and of course, it is very useful, but still very limited in Sierra Leone because we have a lot of other rural settings in Sierra Leone that still do not have it. So I guess one way to actually also reduce or make ultrasonography accessible is by making available the one that is cheap and very easy to use in communities, hard to reach communities, where there is no electricity for the staff or healthcare workers working in those communities to be using it. Okay, so the BabyChecker ultrasound scan has so inavailability in most parts. These are all the limitations. Inavailability in most parts of Sierra Leone or most PHUs, and then of course it is an ultrasound. It is it is a mobile app. Though limited incidents of this have been reported, but like any app, it is liable to malfunction. And of course, if it malfunctions, then you might have difficulties using it at the time when it malfunctions, and you might also probably not be able to get a desired result. However, like I said, a lot of incidents of this nature have not been reported, but like any app, it is liable to malfunction at some point. Okay, so that is one of the limitations. Next slide. Next slide. Next slide. Next slide, please. Yes, so back to the previous slide. So one of my recommendations is that because it is difficult to get a standard ultrasound scan in every part of the country, in every part of Sierra Leone, and with the demand and with the government's desire to reduce maternal mortality, it is important that we invest more in BabyChecker and try to make it available in several parts of the country, because in our communities, we have actually helped, we are having less maternal mortalities now compared to the time when we had the BabyChecker introduced in some of those communities. Because how it works is that at those communities where they are using the BabyChecker, the issues where they are using the BabyChecker, when they detect a high-risk pregnancy, they will refer the patient to a secondary facility, which is our facility, or any other secondary facility. But at the moment, those catchment communities, because they are in our catchment communities, they are referring to us, and then we prompt intervention over the years has helped to reduce maternal mortality. So even in our catchment community, it's relative to the when we didn't have a BabyChecker introduced in those communities or in our catchment communities, now we have a fewer maternal mortalities compared to them. So investing more into it can help to actually reduce maternal mortality and maybe help us to achieve the UN's 2030 supplementary development goal of achieving 70 maternal deaths for every for every 100,000 life paths. Next slide. Next slide. Next slide. Next slide.
Thank you, Dr. Charles, for sharing your experience from Sierra Leone and for highlighting the importance of accessible technologies in strengthening maternal health care at the community level. To all our audience members who have just joined us, before we introduce our next speaker, I want to very quickly remind you that this session is being simultaneously translated in French and Spanish. You can select your language by clicking the interpretation button on the bottom of your Zoom screen. If you have any questions for any of our speakers, please post it in the Q&A panel. We'll have a Q&A session right at the end of this webinar. So our team will monitor your questions and will direct the question to the right person. This chat, the general chat, is only available for greetings and general comments. Our third presentation comes from Ignacio Prieto Egido. Mind my pronunciation. He's the director of the EHAS Foundation and associate professor at the Rey Juan Carlos University. Ignacio will talk about how BabyChecker can transform prenatal care in rural Guatemala, focusing on how the technology supports early detection and training for healthcare workers in remote settings. Ignacio, the floor is yours.
Hello, everybody, and thank you to the Delft team for this invitation. I'm really happy to be here with you to share our experience. I will try to differentiate a little bit what I'm going to explain from other colleagues. It's because we are all using BabyChecker, so we can all share a very similar experience, but I will try to focus on what may be different from our side. So to start, and this, if you can share the next slide, I work in a team, next slide please, that joins or that puts together people from the university and from the NGOs. So, and we work together to verify if the use of innovative technologies can improve public health care in remote areas of developing countries. So previous colleagues have talked about the challenges in these regions, and we try to use innovative technologies such as BabyChecker to improve primary health care in these areas. But we always collaborate with local partners, and we always focus on the public health system. And this is very important in our vision. And we always do an important effort to disseminate the results of our work, of our research. So we have already talked about the challenges in these areas, but I want to emphasize that the very low population density, the scarce resources, and the difficulties in transportation and access are part of these challenges. And for the public health system to invest in these remote areas is challenging because of this low population density. Next slide, please. To address the problem of maternal mortality that we have already talked about, we tried to develop specific solutions, and we started in rural Guatemala, where maybe the more one of the challenges here is that the density of public health workers is very low. For example, they have 12.5 nurses per 10,000 people, while the HSU standard is around 44.5. So they have a very important lack of health staff, like in other similar countries, and not so high like in Sierra Leone, but still high maternal mortality rate. So in this context, we try to design a strategy to address this challenge. And please, next slide. We started with a strategy that we call healthy pregnancy. And this strategy, we started it like in 2012, so more than 13 years ago. And it's based on two ideas. Now, first, to provide local health staff with tools to improve prenatal control and to be able to diagnose risk during pregnancy. So it's like the same goal as BabyChecker, but we started this, like, as I said, more than 10 years ago. And we started with also a portable ultrasound system that initially used laptops, and currently it uses tablets or smartphones like BabyChecker. But the problem is not only the device, but who's gonna use it. And in our case, we started training nurses in a very basic ultrasound test, where they try to identify common risks like malposition, placenta previa, multiple pregnancy. So also we try to measure the gestational age and also the quantity of amniotic liquid. So we did a very basic and very, but quite important ultrasound test to identify this risk and to be able to refer women in risk to a higher level. Instead of having the labor on the community, what means a very important risk for the woman's life, we try to refer them, the high-risk cases, to the hospital so that they can be properly attended. And we completed this pregnancy kit with rapid blood and urine tests that tried to identify problems such as anemia, gestational diabetes, urinary tract infections, or in general, sexual infection diseases. And so with this kit, nurses in rural areas were able to provide a very similar prenatal checkup as women will have in the hospital. Not exactly the same, but very similar. For example, we avoid to identify malformations because it's more complex, and also because in rural Guatemala it's not feasible to provide a solution or advice for women in this problem. So we focused on the kind of things that can be addressed by the public health system with the resources they have in these rural communities. And as also some colleagues has mentioned, energy is a problem in these areas, and it was even more important 10 years ago. So we provided the system with foldable solar panels and with external power banks to allow them to work in isolated areas without power supply and use this foldable solar panel to charge and power the tablet or the smartphone. And all this system is, you can put it in a backpack like the one in the picture, and you can carry it at your back wherever you go, in motorbike, walking, whatever. No? But also we wanted to follow up and to evaluate this strategy. So we designed a health information system to be able to track every woman that were attended by this project. Yeah? And we started the system with OpenEMRs. That is a very famous open source system. And currently we are using the EHAS2, that is also very famous and very used in out of countries. And this allows us to improve not only the prenatal checkup, but also the follow-up of the women's in risk. And next slide, please. So as I said, we started in 2012, and we started by training people, by providing kits. We started with 3 kits in 2012. By 2014, we did an evaluation over 1,000 women, and it was quite positive. And then we get funds to scale up to around 30 prenatal kits, and we were able to provide or improve prenatal checkups for around 10,000 women. And with that, we were able to perform a more in-depth evaluation. But the strategy, as I said, was providing the kit, training the women, also to improve the care protocol, because they were not used to have this tool in the real area. So they needed to have a more clear information on what to do in each case, what to do with each risk, so that the women were properly managed. And so we do a very important effort on training, on following up women with risks, and on coordinating with the public health authorities to improve the whole process and to ensure that women that were at risk had the proper management and that had the best chances to get to the hospital or to the level where they needed to be. No? And so next slide, please. When we evaluated this strategy, we confirmed first that nurses were able to perform this basic ultrasound, and that they reached very good marks on this ultrasound scans, and that more than 90% of the scans had a very good quality for diagnosis. And also we tried to evaluate the impact on maternal mortality over this sample of 10,000 women. And when comparing the women that had access to this reinforced prenatal checkups, when we compared this group with the group that had no access to these ultrasounds, we found out that the improvement in maternal mortality was significant, was important. No, around on average around a 30% of reduction in the maternal mortality rate. However, this figure is not statistically significant, because we will need a sample of around 50,000 women, and we were only on about 10,000 women. But it shows a trend that is quite relevant for us, and that allowed us to keep working on this strategy with our partners in Guatemala, that is Tula Salud, and with the health ministry, to try to improve and scale up this strategy. You know? Currently, we have reached more than 40,000 prenatal checkups in Guatemala, and we keep expanding this strategy. And next slide, please. But an important point here is that the staff that performs the prenatal checkups in rural areas, they don't always have the chance to get this training, and to have a more easy to use device could be a very important advance for us. No? So we started to collaborate with Delft and to use BabyChecker so that it was easier to handle the highest staff turnover that we found in these areas, and also to provide this tool for the people that work directly in the community, because the nurses are not working in the community, they are working in the health center and they visit the community periodically. But instead, nursing assistants, they work day to day in the community and they are able to use BabyChecker to improve prenatal checkups every day. No? So this is a very important opportunity for us, and we started to check this with one device in the last year. Next slide, please. So results in this year are quite promising. We were able to do more than 500 scans with 9 different nursing assistants, and we were able to identify different risks in this sample. No? So we are happy with these results. We think that they show a very promising opportunity, and obviously we will like to try to have more results and to evaluate this strategy in a more deep way. No, because as I said, we have like 40,000 prenatal checkups with the previous solution, and we would like to increase the number of scans also with BabyChecker. Next slide, please. So also we saw that most of the nurse assistants were able to perform good quality scans with BabyChecker, and some of them still need to improve. And in this way, this also shows that follow-up is very important, even when you are using a very easy to use technology such as BabyChecker. No, keeping following up, keeping reinforcing the training of the staff is quite important, and we are trying to do so. Next slide, please. And what we would like to see or do in the next years, first we have checked that BabyChecker is helping us, and it has a great acceptance among nurses, among nurse assistant, and among the women. And next slide, please. We would like to evaluate the cost effectiveness of this solution, because at the end, public health system needs a very cost-effective solutions again, and we would like to check it again and try to persuade the Ministry of Public Health and Social Assistance of Guatemala to integrate tools like this in the protocols, and to be able to scale with more BabyCheckers and to more nurse assistants, so to increase coverage and to be able to decrease maternal mortality in Guatemala, that is not such as high like in other countries, but it's still higher than the goals of the sustainable development goals. So we want to keep working with BabyChecker. We would like to evaluate the cost effectiveness and to scale up this in Guatemala to reach more women. Next slide, please. And just to end, we do a lot of effort to disseminate the results, and to collaborate in webinars, to publish our results in scientific journals. And that's why we are here today, looking for new partners and new collaborations, and to also let others learn from our experience and be able to replicate what is working. Thank you very much.
Thank you, Ignacio, for the inspiring overview and for showing how digital health solutions can truly expand access to safe maternal care in low-resource environments. Next slide, please. Yeah. Our final presentation comes from Dr. Edgar José Velásquez Orellana, a doctor of gynecology and obstetric in Honduras. He'll discuss BabyChecker in the Honduran communities and share how the solution is helping clinicians detect complications earlier, and improve outcomes for mothers and babies. Dr. Edgar, the floor is yours.
Good morning, everybody. Welcome. For me, it's a pleasure to be here sharing this experience with BabyChecker in Honduras with all of you. So to start with, I want to confirm what previous people were saying. BabyChecker is an AI tool that is designed to do these ultrasound scans without having to deal with professionals, like people who really know about this. We need to go deeper into this point because I think this is one of the best advantages of this, because training, as was mentioned before, training is very basic, very easy. Any person that has that can do this training, which is very short and easy, can use this device. And the advantages are many. In Honduras, the idea is to reduce the mortality, especially in faraway areas, rural areas, and people that have low income, low resources. We have to take into account that maternal problems with deaths have to do, of course, with income, and the social impacts of this aspect are many, and it also has to do with with problems with education, with so many things. So it's a very complex problem that involves many aspects of life. Next slide, please. In Honduras, as was previously mentioned, we are facing high numbers of mortality for mothers, especially this is because of the lack of access to healthcare. The pandemic had a very strong impact, especially in patients that were attending the healthcare clinics, because they were looking for this access of health service and self-care. And during the pandemic, a lot of institutes and clinics were closed. So these women who were having risks in their pregnancies and could not access this medical care because the clinics were closed, they had to face a lot of problems, and therefore there was an increase in mortality in this aspect. It meant that the number increased from 61 to 125 deaths for every 100 births. And also, another thing is that in these rural or faraway areas, technology is something that it's lacking. Some areas don't even have energy or internet access. The roads are also not very good, so these are very hard to reach areas. So the quality of the healthcare services there are greatly affected by all of this. So this device, this tool, BabyChecker, came as a help for this so that we can provide better healthcare. Next slide. In September 2023, for the implementation of BabyChecker in Honduras, we reached an agreement with the Health Secretariat, with the WHO, and we agreed on some things, that we were going to use the BabyChecker. We were going to use 5 in hospitals and rural clinics. In the hospitals that we used, these BabyCheckers were in the hospital Tegucigalpa, in hospital Mario Catarino, and also, as I mentioned, in some rural clinics, which, as I was explaining before, these areas are very hard to reach, and where the use of this device was very needed. It's very important to say that the impact of BabyChecker showed the importance, the positive impact. Like, of course, the impact is greater and better in rural areas. So it's very important to say that when getting these devices, it's a crucial point to consider where are we going to allocate this, whether the staff is trained to do the ultrasounds or not, whether they have the technology or not. BabyChecker, I mean, if they have all of these other things, BabyChecker is not that needed. So that's why we mainly allocate BabyChecker in rural areas where they really don't have other devices and where people are not that specialized. So I want to insist on this. It's very important to take into account where we are putting the BabyCheckers. Next slide. So the use of BabyChecker. Back then, we used BabyChecker in October 2024, approximately 1 year ago. We had like a baseline, so we could assess the implementation of this device so that the health secretariat can make the decision to integrate this in the birth technologies that we were using for pregnant women. And we started with this baseline last year. We assessed around 400 women in 3 different region areas, the south of Honduras, La Paz, and the center of Honduras, that apart from being rural areas, they also have a high percentage of different ethnicities, local ethnicities, and this has a positive impact on these people. The nurses and the people that were volunteering in the healthcare services and were able to take the training to use a BabyChecker, they were very happy with the results. They were able to collect the information. So basically, the idea of the BabyChecker is to find out about the gestational age, multiple pregnancies, the positions of risk, and the alert signs that we can find in these cases. Next slide. And then the impact in the community, well, honestly, as I was saying at the beginning, the training for the BabyChecker is very short, so it allows not specialized staff to use this tool and obtaining very important information to find, like in a timely manner, risk factors, and therefore refer this patient to a specific health institution where she can get the proper care. It is also very important to say that this improves the access to birth care services in areas that are extremely far away, indigenous areas. This is a very big barrier. In our country, we have a lot of different ethnicities, and given cultural differences, some people don't even want to be attended or cared by specific ethnicity. So this breaks these barriers and allows us to bring technology to these areas that otherwise wouldn't have it. And also, detection at a timely manner allows us to act with more options to refer patients where needed, and that helps too. Next slide. Okay, future outcomes or future ideas. It's very important to assess or evaluate this pilot project. We presented a report to the health area in our country, and the idea is that they can take a look at this, and we gave them this information report so they can analyze and decide if they are going to expand this in the future, mainly the use of the BabyChecker, especially in the rural areas that, as I mentioned, the people who do the pre-birth controls don't have technology or don't have the necessary technology to provide or help and bring a greater impact in this matter. And one of the objectives for the future is to expand the use of this technology in other regions, to train more people in the use of BabyCheckers so that we can have an impact to decrease this type of problems. And here we have a Lenca woman that when doing the test, the assessment, she was pregnant, and she was carrying her other child on her back. This is a very typical way of carrying babies in this part of the city. As you can see, this is very humble people that are exposed to a lot of risk. So our goal is to save these women and to help them in their care. And BabyChecker was a crucial part of this. Thank you.
Thank you so much, Dr. Edgar, for your such a nuanced presentation about BabyChecker and how it's helping the communities. On this note, we are going to start with the Q&A session. Before we start the Q&A session, a couple of things. If you still have any questions that you want answered, please put it in the Q&A box. Also, just so that everyone here knows, we understand that there are a lot of questions and we may not be able to go through all of them today in today's Q&A session. We will, however, be sharing a Q&A sheet with all the answers to all the questions presented today in a follow-up newsletter to this webinar. So in case your question is not being picked up, please worry not. You will be, your questions will be answered in the Q&A sheet. On that note, I'd like to invite my colleague, Julio, to conduct the Q&A session.
Hello, everyone. Well, let's start with the first question. That is, we already have been answering some of the questions in the chat, at least the ones that were more addressed towards the Delft team. So now the first question that I want to read, this is for the speakers. It's from Kwasi. Like he's saying, like, impressive, very simple and accessible. And some questions that he is asking is, for example, if there are any specific challenges that facilities or entities have faced in adopting BabyChecker and how they are addressed, and how can BabyChecker become part of a broader learning platform for maternal health where ministries, innovators, and partners share insights to accelerate improvement. Please go ahead. Anyone that?
Well, it's a challenging question, quite broad. For example, some colleagues talk about that BabyChecker is very good with people with not training on ultrasound, but you would probably need someone with training on ultrasound at the reference health facility. So yes, you probably need to design a whole protocol on how to use BabyChecker, where to use BabyChecker, how to manage the results, and what decisions will be made depending on the results from BabyChecker, but also who should receive the women after that, and train the people at the reference facility so that they can also manage whatever comes from the rural area. And at the end, I think you need to create a protocol to use BabyChecker, to use other devices, other tests to improve prenatal checkup, and to be sure that at the end you have a continuous follow-up of the women. No? So on that sense, I think that it's very useful to have this tool. You have to have into account where it is going to be used, as also some colleagues have explained it, and train nurses, train health staff, and have trainers, and have a complete set of protocol to use this. And I think it's also very interesting for health staff to also be able to identify risks, more complex risks, because most of the people working in rural areas, they are not aware sometimes if the woman have placenta previa, for example, and now they are able to know that, and so they need to know how to manage this problem. So yes, I think that trainings are very important. It's also it's an important opportunity with BabyChecker, and that it's important to have a system or a complete approach to get the most of this tool. Thanks.
Thank you very much, Ignacio. Do you want to add something, Elijah? If not, I can just go to the next question. So there is a question directly to you, Elijah, which is basically, in resource-limited settings where the BabyChecker is used by traditional birth attendants, how do you communicate the test results to clinicians in public health facilities when a pregnant woman is referred for further care? Considering that the results can be printed and electronic transmission is challenging in hard-to-reach communities with poor or no network coverage.
Yes, so in Sierra Leone at the moment. If I'm to answer the questions with Sierra Leone in view, Sierra Leone in this perspective, we've discouraged and have stopped traditional birth attendants from doing deliveries. So we no longer have traditional birth attendants conducting deliveries at home, but we have now at those facilities we have maternal and child health aides that are working in public facilities, though only primary health centers that of course they do deliveries, of course, but they don't attend to difficult cases. But let's say in those settings where we have traditional birth attendants and then it's difficult to actually communicate the information via electronic medium, you can as well write the results on the paper. We've had a few cases, we have a few referrals we received from our catchment communities with the referral letter written with handwriting. So you can as well write their findings with on a paper using a pen, and then the patient that is coming or the caretaker that is bringing the patient to the public health facility will bring the result of their scan. Alternatively, of course, in the secondary facility, they will always do the scan. So even if, for example, you just write high-risk pregnancy, and then briefly state what makes the pregnancy high risk, of course, it will still be confirmed at the public health facility before further action is taken. So it can be written where possible. Of course, even in Sierra Leone, they don't in those facilities where they are using the BabyChecker, it's difficult to print. So what they are doing is that they write the results on the paper and then they refer the patient to with the written result. I hope I answered the question well.
Yeah, I think that was answered. So then I can also answer one of the questions that was before addressed to the Optimine. So they were asking, for example, like if it works with every phone. At the moment, BabyChecker works only with a specific device that is currently. Let me take out the blur in the image. So which is a Fairphone, which is an Android phone. It currently works on this Android phone, and in the future what we are trying to do is to make it available for any Android phone. So at the moment, like this is basically the device. It's quite a portable device that can easily be taken in any outreach projects and easily be used in a community health setting. Like it also have the probe inside and everything. So I hope that also answers the question that was before. And I think most of the questions have been answered already. Like also another thing that I want to mention related to the last question. So earlier there was an image, but there is still an image, and now it's not even required to be with a verified result. Like you will automatically get an image on the phone whenever you perform the scan that will try to show the best plane possible of the baby directly, so it can be shown within the moment that the scan is being done to the pregnant woman, so they can get a view of the baby in real life. And this view of the baby will be a real picture of the scan that it's been selected automatically with artificial intelligence. So it's nothing generated, it's a real view of the baby for the woman to see, the same as it will happen in a hospital in the Netherlands, for example. I think this, I'm not sure if we are running out of time or not. I think most of the questions will be also answered in the Q&A and in the follow-up, as Katia said. Like maybe we can answer one more. It's the one related to Ethiopia. I'm not sure if you want to, or you can answer that one, Riccardo.
No problem.
Yeah.
I see
So
two actually related to Ethiopia.
Yeah, go ahead, please. Yeah.
Yeah, I see for the Ethiopian experience was the mentorship and linkage to a sonographer or radiographer explored. Well, this was explored as an idea. There is also an idea from the Regional Health Bureau to implement a full-time ultrasound in the facility. There are no general practitioners in the facility, so this is obviously challenging. The linkage, meaning probably a referral, we had a lot of challenges with the referral because many times there are cultural and economical barriers that prevent the women to feel ready to be referred. They don't have a family somewhere else, so many times they want to have a double check with an ultrasound to be to feel ready to be referred. The second question is about the endorsement with the Regional Health Bureau, with the BabyChecker, and then the cost for the EI app, and then if the result of the study of Somali were shared with Ministry of Health of Ethiopia, and how was the reaction about endorsing the system. So in general,
Still hearing you, no problem.
Okay, sorry, we lost the electricity for one moment. We are in rural areas, sometimes also here in Addis. We presented the results, the preliminary results to Minister of Health, and were accepted. So is part of the annual bulletin of Federal Minister of Health 2025. This study. For sure, we will present the result to Regional Health Bureau. Why not to imagine to scale up or to see how to address some limitations. In terms of cost, I have to say I'm not much aware, but the BabyChecker is with us for a while, and we are paying the annual cost, which is not that high. And then we are also thinking to scale up the use of BabyChecker more than in a health center to in a health post that is really the last mile, where we can guarantee the privacy of the women, but at the same time, really there are a very low numbers of health workers, and this can be really one of the tools that can be used for the antenatal care routine visits. These are things that
makes sense in the long term.
Nice, perfect. I will then answer the last question from Bamlaku, and then I think I will give back the floor to Katia for the final part. So to finalize, like the technology, BabyChecker currently does show live results just after seconds after performing the obstetric sweep scan. So it's literally like after you perform the 6 sweep, within seconds you will receive the risk factors that we mentioned during the presentation, the gestational age, the fetal presentation, the placenta location, the multiple pregnancies, and you will also get the cute pic, what we call the cute pic, that is this image of the baby that we were mentioning before. Yes, with this, I think the questions that have not yet answered, they will be answered within the follow-up. And I give you back the floor for the final remarks and closing, Katia.
Thank you so much, Julio. And thank you to all our speakers today for enlightening us and our audience about the profound impact of your work and how BabyChecker is enabling, better maternal outcomes. Thank you to everyone who joined us today for your engagement and thoughtful questions. A recording of this webinar will be shared with all registered participants. We hope you found today's discussion useful and enlightening, and that it sparks new ideas on how innovations like BabyChecker can continue to advance maternal health worldwide. Thank you all once again, and have a great day or evening wherever you're joining from. Goodbye.